Nick Majerison here, welcome to TopMedTalk. Today we have a conference highlight called Give Your Patients a Warm Welcome. The conversation features Professor Monty Mythen and his guest Mark Harper, consultant anaesthetist at the Brighton and Sussex University Hospitals, with a research interest in the prevention of perioperative hypothermia and the use of cold water adaptation for therapeutic purposes. Have a listen.
TopMedTalk. Okay, so bringing it back to the clinical scenario, what we were discussing today, you were presenting, we were looking at some great technology that can help us to stop this happening, is around the time of surgery, it's easy to get cold.
Completely, yeah. It's easy to get cold. First, when you just come into hospital, because you become a passive, patients become very passive.
Yeah.
And you're just sitting around, you're in an air-conditioned environment, you can get cold, and certainly peripheries can get cold very quickly.
And anyone who's been a patient or even been in for tests will know it's quite hard actually to get enough thermal things. Everyone else is thinking about themselves in the environment who's working there, and the patients are often stripped off and barefooted or whatever it is and actually getting cold quite quickly. And that's not good for you, is it? You're not suggesting that's therapeutic? That's
not good for you. Again, you do not want to become hypothermic. You become cold. And the other problem with that, though, of course, is this business of core peripheral redistribution. Because the majority of cold, why patients get cold really in the first 30 minutes after the induction of anaesthesia is redistribution of heat from a warm periphery, from a warm core to a cold periphery. So it all equilibrates throughout the body.
Okay, so I'm at normal temperature in the majority of my body in the centre, but the edges have cooled off. So once you put me off to sleep, my natural mechanisms get overridden, and all the stuff rushes out into the periphery, so that all of me cools down.
Exactly.
Is that right?
And the issue is that if your core is warm, and so you're sitting there with like really cold legs and really cold feet, if your core is warm, you'll actually probably feel reasonably warm as well.
So therefore, I think part of what you're suggesting earlier is a lot of effort should be put into keeping people's peripheries warm before we put them off to sleep.
Yes, I think that's it, and that's the thing about pre-warming. So the total body heat content is maximal, I suppose.
So we've spent for the last, as long as I can remember, I suppose it started 15, 20 years ago, we put a lot of effort into warming people when they're asleep on the table. But we've probably lost a lot of ground by that stage. So you're suggesting bring that forwards, is that right?
I'm suggesting do both.
Okay.
I think we need to warm them when they're on the table as well. But to really make progress, we need to bring it forward as well. But that's logistically slightly more complicated.
And practically at the moment, how do you do that? Is it more complicated than duvets and blankets? And
it depends on at what stage your patient is at, really. If you get a duvet, if you insulate a patient, which is what a duvet will do, if you insulate them early enough and their periphery is nice and warm, that's absolutely fine. But by the time they've got cold, by the time the peripheries have got cold, by the time the total body heat has gone down, that will not be enough. You need to start putting active warming into the system.
So go back. So here I am. Let's skip over my age, size, and all that sort of thing. I've been in hospital in the last year or so. Arrive early, strip off, get one of those gowns that doesn't do up at the back so your backside's sticking out, have bare legs, be told that something will happen to you in the next few hours, stay in this bed space and remain a coiled spring. And you're gradually cooling. And that's fairly common, isn't it? I'm not exaggerating.
Yeah, fairly common.
So
absolutely. Very common, too common.
So from the moment we do that, what should we be doing as an alternative?
I think there are two ways, two approaches. One is you can put active warming, so active external warming, which is, I think the most practical way of doing that currently are these self-warming blankets. The Easy Warm is the most common one. And then you put one of these, you crack them open, some iron oxide reacts with the air and they generate heat. And a very specific reaction, it will generate heat to about 38, 40 degrees. You put that around you and that will give you active warming and insulation. So that's one way of doing it. The other, which probably a bit more controversial, but I think from our studies of cold water immersion is really the way that would be most effective, is to keep active, and keep active either by walking around or get on an exercise bike. I really like to put exercise bikes in pre-operative areas and get people to, if they want, just go on. Just go and spin it a few times. Maybe put a podcast up so they can listen to a MedTalk podcast while they're doing it.
TopMedTalk.
This edition of TopMedTalk was recorded at the Institute of Sport, Exercise and Health, live from an Enhanced Recovery After Surgery Leadership Forum. And this particular piece was taken from a longer conversation to be found under the title Cold, Kill or Cure, live from the ISEH Part 1. Don't forget, of course, you can meet the TopMedTalk team. We are regularly in attendance at the EBPOM meetings. Go check out their website, ebpom.org.